Welcome everybody to this webinar hosted by JBS International for the OJJDP Building Local Continuums of Care project. This is the webinar on the integration of youth populations with situation tables. I'll pass it to our presenter for today, Scott Allen.
Well, thank you. Good afternoon and good morning. Carlos, it's not 108 here in Massachusetts, but we're going to hit the 90s next. For everyone that's joined on here, thank you for joining us today. My name is Scott Allen. I'm going to share my screen in a second here, but by way of background, if you can put in the chat your name, your agency, where you're from, that would be great so that we can share here. I always love to do these sessions in person. It's always hard on the virtual setting, but I'm going to try to engage as much as we can. As Cody said, this is the integration of youth populations with situation tables. And I'm going to have a quick little in-class poll in a second to get a feel for what you might know about the situation table. But if you haven't heard of the situation table, you're probably doing some work in this space anyway, because what the table is, it's bringing partners together to collaboratively problem solve. And in particular, we're going to talk about integration of youth populations as well as the family support. So I'm going to do my quick screen share here. I just tested this out. And Cody, can you see my main large screen?
Yep.
All right. So thank you for being here. So my name is Scott Allen. By way of background, I spent 26 years in law enforcement in Massachusetts. If you told me about 30 years ago today I'd be doing this work, I would say you're probably not with all your faculties. I started off in corrections for a short time, then I was a police officer, and then I ran a drug task force. I was a drug task force officer, then a commanding officer for a better part of my, say, 22 of my 26 years. The only tool in my tool belt that I learned in the police academy in 1995 was to identify drugs and make arrests, and that's what I was trained to do. For me, my aha moment was getting involved with a local community coalition called EB Hope, started by a mother whose son was in the throes of opioid use disorder, that wrote letters from everyone from the governor down to the chief of police, my boss at the time. And she said, where do I turn for help with resources for my family, for my children, my child who's struggling with OUD? And then that was kind of my aha moment. I started to change the way I was looking at substance use, mental health responses, looking at it from this holistic approach, from police trained to, hey, how can I do this through a community-based law enforcement, public health-led lens? And that's what I did in my community. In our county, we started a group called Plymouth County Outreach, 27 cities and towns working together to problem solve. So it started because of opioid use, but it quickly led into other areas of how do we provide these wraparound services for families, the persons in need, the families, and most important, what are we doing about the children that are living in these homes? The Handle with Care model that Andrea Ja started in Charleston, West Virginia in 2010, 2011. We started to introduce this through this conduit. So I wanted to kind of give you the framework for where I come from, because I went from being that police investigator to, they used to call me, I became the police chief for 4 years. They called me social worker chief. And I took it as a badge of honor, because we were using our front row seat in law enforcement to help those in need in lieu of arrest, in lieu of the justice system. By way of background, I was going to be a teacher. I was going to be a football coach. I taught one semester at the high school level. I said, I think I'm going to be a cop. But teaching is my passion, and really working with partners is my passion. What the table is going to show you, we're going to give you the framework, what the approach is. I didn't create this. It's been around since prior to 2009. It came from Glasgow, Scotland, to Saskatchewan, to Prince Albert, Saskatchewan, Canada, down to the US. I'm going to talk about how the table will integrate with youth and at-risk youth, their families, and all those support systems. I'm going to talk about this through the best practices. Tables are now recognized in the US as a model best practice, and I'll talk about that. And I'll talk about how can a table be applied and engaged with not only your targeted youth populations, but again, that whole family, that whole system approach. How can we help families, children, and those people at the same time? So again, I gave a prelude to this, and Cody, jump in and tell me if I've rambled on too long, or I'll give you a time check. I've got my clock on here at my wrist as well. If anyone has any questions and says, "Say, Scott, can you slow down?" Put that in the chat, and Cody will monitor that, because if you can't tell, I have a hard Boston accent. I apologize in advance. If you need me to put the subtitles on, I'm more than happy to do that, because I go different places across the country and I find that it's hard to hear me at times. Thanks, Carlos. I like to have fun too, so I'm going to try to do that here as well. So the group up in Canada that started the first table, their founders, they were public servants in their public safety, public servant roles. They started the first table based off of the Glasgow, Scotland model. They did it in Prince Albert, Saskatchewan, because they had a high risk of crime and criminal involvement in their community, violent crime. And what the table did is they brought the table in to address that one area. But what we find with all these tables is they start off with one issue, but it truly is this all PELS approach. We're looking at upstream families and individuals and children that are what we call acutely elevated risk, so that we can share information across the table between our community partners to identify these individuals before a crisis happens. And for those that know the sequential intercept model, think of sequential intercept 0. You still have to call a crisis line or call 911 or get arrested or go to jail. The situation table, we want to be -5 upstream. How can our shared information work to address the needs of individuals and families, and particularly here, juveniles and youth? How do we help those individuals before something bad happens? Now, I retired in 2020. Again, my background was law enforcement, but I very much think of myself now as a community-based public health collaborative, professional with some law enforcement experience. Most of the tables that we launch and do, law enforcement is part, but they're only a small piece. They're an important piece, but our public safety, our public health, our schools sit at our tables because we have this shared knowledge. And again, we want to look upstream. I'm going to pause right here and ask everyone if you can screenshot that real quickly, the Slido tool, the room code at the bottom. If you can either screenshot it and open that survey. I want to get some quick feedback from the room and the audience to get a gauge for what your role is in the community. And you'll see there's like 6 different questions. If we can take 2 minutes to do that, please do so. And I'm hoping like heck that it's working in real time. If someone can let me know they're in there verbally, like I'm in and I'm doing the survey, that would be real helpful.
I'm in there, Scott. I just
Awesome.
scanned the QR code and it let me right in.
Cool.
I'm also in there and I can't use technology, so.
I'm in, Scott.
All right. Well, that's great. That's good. I passed. That's phase 1. Now the phase 2 is going to be, I can see people typing, so that's perfect. I can see everyone typing away vigorously. I've got it's like 8 or 10 now, 9 people typing. That's good. $11 responses going. Awesome. Give it another minute here. All right. So you can see there, look, it actually worked. Thank you. We got a grants project manager. We got a TA provider, volunteer nonprofit board member, direction of recreation senior services, our elderly population, key partners at tables. So we get the elderly population and the students and the youth population. Library. I love the library. The library is a place where we actually host situation tables. The table meets once a week. It's the only action-driven meeting that you will see, and I'll talk about that as well. State Health Department, I work with state health departments all across the country. Department of Public Health and Human Services in Montana, Kentucky, West Virginia, school health policy. I love it. Good stuff. Youth Office, Minnesota, Department of Public Safety. Thank you. Rhode Island. We have tables in Rhode Island. I love seeing that. There's tables in Woonsocket, help me, Newport, Middletown, and we're going to be in East Providence. So my Rhode Island friend here, if you're in any one of those, I think East Providence is going to lead us into Providence as well. Great stuff. All right, so roles. I'm scrolling down here through. Housing is the #1 risk factor, unhoused population we see across the country. Love it. Great stuff. My community is engaged in proactive outreach to address substance use disorder. Are you seeing the poll in real time on my screen? Just want to make sure.
Yes,
Perfect.
we are.
93%. I love it. So we're all doing this work. And then what do? Continuum of care, MTSS approach. I love it. QRT. My partner, Dan Malloy, created the first quick response team in the country in Coleraine Township, Ohio. Prevention Coalition, Kent County, nonprofits at the table. CIT, we don't create these initiatives to compete, we collaborate. We have CIT teams at our tables all across the country. I love it, love it. Homeless outreach, veterans outreach, key stuff there. Community Partnership Task Force. Don't build something new. If you have a task force, we want to ask you, use the table, build it as part of that collaborative approach. Narcan public safety training, adult protective services, all great stuff. I love it. And I'll share this with Cody to share back to you. So this is great. 78% of you have never heard of the situation table. So this is the right audience. It used to be called the Chelsea Hub. The first table is in Chelsea, Mass. We don't call it that purposely for several reasons. One, each individual, each family is a new situation. No one situation looks the same, and each wraparound service is going to be different. And there's a lot of hubs out there, the hub and spoke model. Sometimes people get confused. So that's why we talk about the situation table. And then what are your biggest social health challenges? Housing is #1. I knew it would be because we see it across the country, whether it's Vermont, Rhode Island, Massachusetts, Chautauqua, New York State, Ohio, West Virginia, the Panhandle Health District in Nebraska, Corvallis, Oregon. We're going to have a table soon up in Montana. Housing is usually #1. #2 is usually mental health, which I see is right in alignment. And then usually #3, I always thought substance use would be #3. Substance use is usually 4 or 5. Alcohol use disorder still kills double the population, the opioid use disorder, but combined, alcohol and substance use disorder are typically right there. I love seeing diabetes. This table is designed for that all perils approach. You'll have situations that have health issues, elderly population that need resources and services. So I love seeing that. Food insecurity, all stuff that the table is designed to address. Think of social determinant health needs. That's what the table is going to tackle. I'm interested to learn more. Good. I'm glad we don't have any no's, because then I'd tell Cody to make sure we find out who the no is, and we're going to entice you to become a yes. All right. So what is a table? I got to laugh out of someone. Thank you. And I know that Boston accent is hard for you. I didn't realize. I thought it was everyone else that talked funny across the country when I went to all these different places, but I now realize and accept that it's me. So the situation table, it's unique. It's risk-based, rapid triage. It has fidelity and structure. I'm going to give you the 45-second or 45-minute left that we have left here, but I'm going to, 45 minutes. I'm going to give you the quick notes version, but it brings together multiple human service providers. No one agency owns a table. We are truly a community table. There'll be some different roles. There'll be a chair, but think of the chair only as a facilitator. The chair is going to make sure that the table stays on task, that we follow the fidelity, we follow the structure, we follow the process. You're going to hear us refer to a term that the Canadians coined, acutely elevated risk. For our US-based partners, think of those in acutely elevated risk, those that will be in crisis if we don't intervene. And it's not just the individual. Almost every individual situation has that family component, because we have children that live in these homes. The child or the youth could be the person we present as a juvenile situation. But even if we have a family or an adult situation, we got to make sure we're looking out for the needs of those juveniles. Think of adverse childhood experiences. Mom and dad are at risk because of substance use, alcohol use, mental health crisis. They've got 3 children. We should be providing wraparound services through those children through the table. So it very much complements those efforts. And then think of those individuals at the highest composite risk. A key to the situation table is that a situation has to cross several service sectors. If there's one agency at the table that says, hey, I just heard those risk factors and I provide all the services for that, which is not often, then I should be doing that as a single agency. But almost every situation you're going to hear is going to cross those multiple service sectors that, if alone, we couldn't navigate through that system of care alone. But because we provide a wraparound team for that situation, that's the secret sauce behind this, the magic. My mother right now is 76 years old. She's dealing with all kinds of health issues. She's got cancer. She got kidney issues. She's got heart issues. She's got, I don't know, she's got other issues. I'm having to quarterback her medical care, and it's an absolute disaster to try to navigate 5 different specialties. Think of that situation being on the behavioral health side where you're the situation, the person in need. If you have to navigate 5 different providers, it's most likely, it's doomed to fail. But the table recognized that and said, hey, we're going to put together a wraparound team to deal with these situations. And what the table does not do, we don't do case management. We reduce risk, we put the person on the right pathway, and we have the lead agencies that can be responsible for doing the case management with those partners down the road. So think of those that slip through the cracks. What the key benefits are, and again, I had the benefit. I was the police chief in my community. We started a quick response team because of the opioid crisis. We got all 27 cities and towns to do it collaboratively, which to get 27 police chiefs to work with our behavioral partners and hospitals, to get them to agree on lunch was a challenge. But we were able to do it because we all saw the key benefits of work, breaking down silos and working across these sectors. And that's what the table does. We respect privacy. If there's anyone in this room, and I'm assuming there are, that are HIPAA bound, CFR 42 bound, or have some kind of privacy protections, the table does not circumvent that. The table, we're going to hit that head on. We've got a great release of information that we're going to propose presenting to the table in advance, telling someone, hey, I have this situation table I'd like to present you to next week. They have a lot of wraparound services that are outside of the services that we can provide. Will you sign and allow me to present you? I'd say about 60% of the time, I know in Vermont, 60% of the time we're getting written consent in advance. We actually have tables now where people in the community will say, hey, I heard about this situation table. Can you present me? I'm in need. I mean, that was in Springfield, Vermont, where someone did that. And again, we're focusing on risk factors, not incident driven. For anyone that's a public safety, a fire, EMS, that's what we do well. We take a 911 call, we respond, and then we triage it. But what we don't do well, and I'll say this having done it for 26 years, we don't look at those social determinant health needs when we're at these calls. We don't identify what are the underlying reasons why we're here for a 911 call. That's what the table does. But we do it as a community so that no one agency is responsible for having to take it on, and then no one agency is going to own this table. It's truly a table that will meet the needs of all risk factors, including that high-risk youth, young adult population. Now, I pause for a second to say, most people in the youth sector will say, hey, we want to set up a table that does just youth integration, youth situation. And I'm going to tell you, the Canadians, the Scotland individuals say, don't do that. Make sure that your youth integrative providers are at the table, because if you're only bringing youth situations to an isolated group, what you're going to miss out in is, what about mom and dad? Who can provide the wraparound services to mom and dad that may be the cause of the youth's acutely elevated risk factors, and then vice versa? We're going to have mom and dad's, adult situations that we're going to ask. Are the children in the home? Yes. What are we doing for those children that may not be at risk now, but they will be? And when we present these situations through what we call the 4-filter process, we'll use de-identified at the start. We'll only provide identifiable data with the release of information, or if your agency can provide that information. Oftentimes, law enforcement partners, I could do it in my community. I could share a name, an age, and an address one way to my partners, and then they could work the magic. They couldn't share the information back, which we never asked them to do. But law enforcement can often share names of family members, loved ones, and then students. Are your school resource officers at the table? Are your behavioral health clinicians, social workers at the table? If they're not, they should be. Again, that high level view of what the table is, it's agencies working together across these sectors that oftentimes we don't work together. I can tell you, until I got into this space, 2012, 2013, I didn't know who my community-based organization providers were. I knew who DCF was for child welfare, but I didn't know all the youth service agencies that could provide resources. And when I was at a call for service, a domestic that had kids in the home, if I filed a protective order, that was probably about the only thing I did as a police officer. Now through the table, I can introduce a situation that will target those youth in need. And then all those service providers, community-based groups that are there, the groups that you are from, will be sitting at the table saying, hey, I have some resources that can help that situation, and I should probably be part of that outreach team. No one agency owns a table, and no one agency should be limited to participating in the table. Everyone's invited. Real quick, the 4-filter process. I'm keeping track of my time, Cody. I'm at 22 minutes in, so again, I have a tendency to talk quick. So if there's any question where someone already said, Scott, slow down, remind me, Cody, because again, I get going. I'm a little bit passionate about this too. I love this work. I know you love this work. That's what we have in common. So I'm going to be on the right-hand side. All perils approach. Whole system of care. We're looking at the person in need, the families. We can even look at neighborhood situations. Or I have a juvenile situation I'm going to bring up in a minute from Southeast Arkansas, where it was a gang-involved youth that was unfortunately killed. But I'm going to share how the table helped in the post-traumatic part of that situation and where the table missed getting upstream in advance. We're going to talk about situation table numbers. You're going to hear me refer to the risk tracking database. The only data we collect is de-identified, and it's the specific RTD that originated in Canada. There's 120 to 150 tables in Canada. There's now over 40 tables in the US. So that's about 160 tables across North America. We all track the same data. We don't change. You don't add your fields. You'll see there's a robust tracking data capability here, but you can't create your own data because every table runs the same way, operates the same way, respects privacy, and we track the data the same way. And the data is pretty impactful. Information sharing is restricted to what your day-to-day life works like now. If you can share information, but only through a release of information, that's how the table will operate. We do have a non-disclosure agreement that everyone has to sign one time. If there's a guest that comes in to do a situation presentation, they have to sign that. We are all about respecting the fidelity of this process. Again, it's a structured 4-filter process. And we're going to be looking at those at acutely at risk. So the first filter happens in your agency. You identify an individual or family that your team or agency has been working with, but they just keep on slipping through the cracks. And you don't have the capacity alone to provide the resources they need. So you're going to bring that situation forward at a filter 2 situation presentation. That happens at the table. Now the table meets once a week. And I know when you hear that, you're like, oh, I can't do another meeting, Scott. I'm telling you right now, you'll rearrange your schedule for this meeting. Every table does across North America, because it's the only meeting that I have ever been to where it follows a script, it's action driven. We identify key partners that are going to work together, and then they go off outside the meeting and do the magic. We don't case management at the table. We put together the team that's going to go out and do that case management. And then here's the big thing. they're going to have to report back the next week. What did the situation tables outreach team do? Have they put the person or family on the path to success, but still going to keep it open? And they're now going to have case management. So it's very much that action driven, and there's accountability, and we're tracking all that, all de-identified. And then, so filter 2, we meet 9 a.m. every Monday morning. The table chair will follow the script. Do we have any news announcements? Real quickly, you want to announce job postings, etc. No. If not, do we have an open situation from the prior week? The first time out, you won't, because you're going to bring forward the first situation. But each time the meeting convenes, there'll be an update. And the update only refers to the situation number, a summary of what the risk factors were, and then who was part of the outreach. And then we ask one person, give us a de-identified update. That's what happens at filter 2 if we have updates. So for the first situation table, let's pretend we have no situations. We have the new situation being presented. I have a 20 to 29-year-old male that has 3 kids. The 3 juveniles are truant from school. The dad is a single divorced dad. Mom is in substance use treatment. She's not involved with the kids. Dad is struggling with mental health disorders. He is unemployed. They're going to be evicted from the house within the next 30 days. Does that cross several service sectors? It does. Is there one agency that could problem solve that today? Not necessarily. But everyone that's at the table on behalf of their agency and the services you provide, they're going to hear that. And when we get to filter 3, they're going to put their hand up. So filter 2, that's what a de-identified discussion looks like. Then the table chair is going to say, having heard that limited information, do we all believe our shared knowledge, experience at the table? Do we believe that that family is at risk of harm? We're all going to say yes. Do we believe that harm will continue to occur if intervention doesn't take place? We're going to say yes. Then the table chair is going to say, therefore, are we at acutely elevated risk? We're all going to say yes, because what that term coins is, if we don't help that family, something bad's going to happen. It could be tonight. It could be tomorrow. It could be next week. But we don't want to have to wait for that 911 call. We don't want to have to wait for the crisis call. We want to get out in front of it. So if the table consensus, and that's how the table operates, by consensus, the majority of the table participants say, yes, we are at acutely elevated risk, then therefore we're going to move to filter 3. Now, for some reason, if we didn't think that we were at acutely elevated risk, we'd have the table chair would facilitate a discussion. Andrea, why don't you think we're at acutely elevated risk? And you might say, well, I have all those services. I think I could help that family alone with my agency. Not likely, right? So we're most likely going to go forward. But there might be a situation that gets presented that's only one risk factor. And if it was only substance use and no kids in the home, substance use treatment might say, you know what? I can take care of that situation alone. But it almost never happens. I'd say less than 5% of the time, it's probably more like 2% of the situations actually get declined because someone can already provide those services. So at filter 3, we do 2 important things. The first is we ask to share the name, ages, address if you're allowed to, because that's what we call recognition. And it's important for multiple reasons. One is someone at that table will hear the name or the address, or the school resource officer will hear the kids' names and say, I have recognition, if they're allowed to. And what that table tells the table is, I should be part of the filter 4 team we're going to put together. What it allows is de-identified, even if you just raise your hand and say nothing else, that is recognition. Because the other important thing that we're doing at filter 3 is we're going to put together a filter 4 outreach team that will go out and engage that family within 24 to 48 hours. And that's going to happen outside the table. So at filter 3, we're doing recognition. The school resource officer might say, I have recognition. And that's all they say. And then I might, as the table chair, say, can you share more on your recognition? And the school resource officer would probably be able to say, we've had involvement with those 3 kids. That's it. Or that address. Now we start as a table. what agency should be part of that filter 4 outreach team based off of the factors. Not who wants to be part of the outreach, but who should be part of the outreach. And you might be at the table representing your agency, but you're not going to be the person. You're going to say, elderly services should be part of it, but it's not me. It's going to be our casework. Or the school clinician might say, we should be part of that filter 4, but it might be the school resource officer with the behavioral health specialist. So filter 3, recognition, we're putting together a filter 4 team, and then the table chair is going to say, now that we have a filter 4 team together, do we have any other new situations to present? If we do, we go through that whole process again. We don't do anything yet with that first filter 4 team. That's going to happen at the end of the meeting. If we had another situation, we would go through the filter 2 process, filter 3, put together a filter 4 after recognition, and then have 2 filter 4s. At the end of the meeting, the table chair will follow the script and say, do we have any other situations? When we all say there's no other situations, the table chair then says, we're now going to move to a filter 4 offline discussion. The filter 1 team, the first filter 4 team for situation 1 is going to stay in the room, only them, and they're going to start to put together their plan to engage that family situation based off of the risk factors. And then they work together in a small group for the next week. They try to get out there within 24 to 48 hours. And then what we do at the table, say who's going to take on the lead agency. The lead agency doesn't do all the services. They're the quarterback of the situation. They're going to report back on behalf of that table's outreach team at the next week's meeting. If we had 2 situations, each filter 4 outreach discussion would take place separately. Again, we don't want to overshare. If there's people that aren't part of the outreach, they don't need to know that, nor should they have that information, because we want to respect privacy. I'm going to pause for 1 second and just say, how are we doing on time, Cody? And do we have any questions in the chat or yet?
I'm not seeing any questions in the chat, and we're you should be about halfway through your presentation.
I am. Trust me, I told you I talk quick. All right. So these are the risk categories. If you look at the work you do, I know everyone. Oh, go ahead.
One question just got sent. Are there
Yep.
examples of how situation tables have reduced system involvement for youth, particularly in mental health or juvenile justice?
So what we do now have is some data I'm going to show you from the risk tracking database to show the interventions that we've targeted with youth populations. I would share with you that we are now, we're about 5 years into this, and we're looking to publish in this space. I can give you a lot of qualitative data. The quantitative data is what we're now building through our network. We actually host a quarterly convening of tables, and that is some of the data that we're looking to be able to highlight. What we can share early on is that calls for service do go down for our public safety, police, fire, EMS. Emergency department visits do decline. I'll share with you the table in Massachusetts, Holyoke, Massachusetts. 70% of their situations come through the school district, and I can share their outcome data with you. So I'm going to show you the Holyoke risk tracking database because they bought in hook, line, and sinker. They're the biggest referral source, and what they have seen is a positive impact within the school district. So I'll pull that up before we go off today. Great question. These are the risk categories. There's 27 of them. You're going to find within each of these, there's 105 risk factors. So that's that data component that we've never changed. We've made the language, or we're making the language more US friendly, because don't forget, this originated in Canada. So even some of the spelling of the terms is still that Canadian model. But again, we're going to track who the originating agency are. What are the risk factors? We're going to track all that data through this risk model. Again, it creates accountability. There's no one owns the table, but we're going to have a data chair and a backup chair. We're going to have a data recorder and a backup recorder. No one owns the database. You all have access to it because, again, it's de-identified. We're going to look at those risk factors. We're going to be able to answer that juvenile population question. Hey, what kind of an impact are we having in the community? The RTD alone is not going to show that, but the RTD with your local provider EMS data, with your hospital data, with your school discipline data, what we'll do is with the Handle with Care initiative that Andre Dar and the team do at JBS, we'll be able to look at those Handle with Care referrals. I'm hoping early on we're going to see them increase when the table launches, because that means more situations are getting presented to target those youth. When Holyoke's data showed 70 referrals from the school, everyone said, oh my God, the school is in disarray. No, the school is now has a conduit to bring situations together that they couldn't solve alone, but now through the community table they can. The group that I work for, we have a collaborative, secure model. Every risk tracking database is yours. You have secure access. You control who has access. But what we can now do is we can compare sites across the country. It's pretty cool to see what it looks like in Chelsea. You can see tables. We got them all across the country. There's 12 in Kentucky. We got, I think, 20 in Massachusetts now. There's soon to be 8 in Vermont. We have 4 active, 2 next week we're bringing on, and then 2 more in the fall. Corvallis, Oregon is, we have 2 out in Oregon. The Panhandle Health District led one in Nebraska. It is recognized as a best practice by the National Association of City and County Health Organizations. Say that 5 times quickly. I call it NACHO. I think we're supposed to call it NACO, but I call it NACHO. NACHO is, we're actually presenting, my partner Mike is presenting out with that group from Panhandle at the International Convention of, or the National Convention of NACHO next week in Anaheim, California. It is recognized as a peer-reviewed model best practice. Vermont, we're really growing a lot in Vermont. Drew County, Arkansas, I'm going to share real quickly. So they had a 15-year-old juvenile. He was gang involved. He needed to get out of his environment. So the local partners had a camp where they could send him away for 6 or 8 months to get him out of that dangerous environment with guns and stuff. He was going into the program the next day. The mother and father were not enrolled in Medicaid or Medicare. I always screw up. They weren't enrolled. They didn't know how to get enrolled in Medicaid. Unfortunately, the 15-year-old didn't get into the program. The next day, he was shot and killed in a gang incident. So tragic situation. Obviously, upstream, a lot of partners missed those risk factors. Unfortunately, with that fatality, what the table did is they presented the situation twofold. One, for the family. We provided grief support to the family and trauma support to the school district, because all of those fellow students were dealing with the trauma of having their classmate lost. So it served in the post-triage some benefit, although we didn't avoid the tragedy. The second part they did is to say, make sure this never happens again. The situation table presented a community awareness event, advertised it through the school districts to all the families in need, and said, if you need to get enrolled in Medicaid, we're going to have a community event. All the providers were there to provide the resources, and they enrolled everyone for free in Medicaid who was eligible. So again, a negative, I mean, that is the worst case scenario. We missed the mark. But the table still did that triage approach. Why is the table different? It's upstream. You know, typically we're isolated. We are all in silos. We do great work, but usually it's 1 or 2 of us together, but never at a truly community table. That's what the situation table does. That's how it's different. It's collaboration to the nth degree. Who should be at the table? Everyone. You can see schools, child and welfare services, emergency service, workforce development. Think of the needs. It might be housing, job development. I need a driver's license. Have those providers there. Law enforcement, fire, EMS, schools are great referral sources, and then they often take a step back and let the providers do their magic. We have Department of Corrections, probation and parole that are now chairing tables because they see that cyclical in and out of the jails and the prisons. Now, simultaneously, we see the kids that are victimized. They're traumatized by their mom and dad, brother and sister going through the jail system. So now we're able to address those needs simultaneously. So you got corrections alongside your youth engaged. Then you have your elderly population, hoarding, loneliness, mental health disorders. Again, we can do all these services at the table. Why it works? It's a new way to do business. A script that you follow. It's not, we're not having a meeting for the sake of a meeting. We have tables that meet for 22 minutes. Open two situations, we close two, no new business, let's go, we move on. That's how the tables operate. We don't sit around just to talk. And what will happen at filter 3, the natural tendency is someone will want to overshare. We're going to say, stop, too much. We're already at filter 3. We got a team together. That's a filter 4 offline discussion. Particularly with your integration with the juvenile population, that's going to be a challenge because we all know because of FERPA and juvenile, we need to respect that. So oftentimes what I envision with the juvenile participation, probably going to have a release of information or can't share identified information maybe, or have your school resource officer or the police prevent it on behalf of your juvenile population so that they can get it into the queue so the table can work its magic. I'm going to skip through this because this is our table. It takes about 4 minutes. I'm just going to fly through it, but it highlights our table in Corvallis, Oregon. I'm going to show you some data in a second because I want to be mindful of time. So I know I've talked a little bit. So why it's important for youth populations. It is this holistic wraparound service approach. It's not just for youth. It's not just for families, not just for individuals. It's for everything, but it's going to address your specific needs. If you start the table to target juvenile populations, which is what they did in Southeast Arkansas, what we're now doing is bringing family situations for substance use, mental health, while we're addressing the needs of the juveniles. It addresses risk factors that are faced by youth, gang violence, gun violence, adverse childhood experiences, bullying. You know, we have bullying victims that get presented as situations, and we then find mentors, that big brothers that are at the table say, hey, we have a big brother program. Let's connect. It promotes upstream early intervention support. It fosters long-term positive support. Oh, I already had this. So for my school partner out there, this is why the table works. Holyoke, and this is, I think it's probably about a month old, but they launched in 2022. You can see they had 81 situations of individuals, 31 of families. Out of those 81, 71 of their situations were 12 to 17 years old. So that's their target population. Now, Holyoke is a very diverse community. You can see there are 47.6% Hispanic population, 43.5% white, 21.4% are youth underage. So 1/5 of their population is under 18. That's why the table had the need. Holyoke Public Schools are the lead agency at their table. They're driving the table. But we're also bringing in those other situations, those families, to meet their needs. Again, Holyoke specific, you can see 78% juvenile adolescents involved. Another 14%, 9% is intimate partner violence. And then 84% of the situations have children in the home. So as we talk about this integration of youth, that's what the table does so well. We're providing comprehensive support. We're not doing any siloed efforts. We could have a situation that has 5 partners that are going to be part of the outreach. 2 of the partners are going to work with mom and dad. 1 of the partners is going to work with the kids. The other 2 are going to sit back in a secondary role. We're here when you need us for support. It enhances communication, collaboration. I can tell you that these tables that we see across the country, it becomes that one group that you don't want to not be a part of. And again, you can see the breakdown. These are the agencies at a table that is very much juvenile centric. And you can see it's very diverse. Legal aid, clinical services, Hope for Holyoke, Housing Authority, the Health Center, Medical Center. We got hospitals at the tables. The public school, 18 of the situations. United Way of Pioneer Valley, counseling centers, behavioral health centers. There's no agency that's dominating. It is truly a collaborative approach. And again, the strategies, how I look at it, it unites youth-friendly communication methods. It allows, that youth to be considered, because oftentimes those are the kids that slip through the cracks. We're working on the crisis, but we forget about those kids that live in those homes. And we're able to provide safe, stable environments. The National Best Practice, this is that group out of Panhandle Health District, the National Association of County and City Health Officials. So they got peer reviewed in 2023, shortly after they launched in 2022. Last July, they got peer reviewed again, and they're now a model best practice, which is pretty cool. And they're going to be able to share that. Their school juvenile population are involved in a lot of their situations. The other table, and you'll have this PowerPoint available. So you'll be able to click on the panhandle. You'll be able to click on that. It's actually a 19-minute National Public Radio feature on the Corvallis, Oregon table. It's pretty cool because it's a captain from the police department who was the champion to start it, but then it was a behavioral health provider. And then the magic at their table is pretty amazing. I think they just hit their 100th situation in just over a year. You'll have access to this. This is an example of one of our Vermont tables. Well, how do I get who brings a referral forward? Anyone can bring a referral forward. How do I do it? So we have these little walkthrough procedures. If you have to get a consent, this is how we do it. Feedback from our table trainings. When we do these trainings, we do get some, real impactful. It's not just about the model, the structure, and the process, but the learning that happens, not from us, but from each of you. Because what we do is we have everyone in the room at the same time for 2 days. You're going to have a school partner, behavioral health partner, a gang interrupter, a police officer with a fire, and we're all talking, hey, what is your space? How can we collaborate across this table and break down silos? Now, I did go fairly quickly, so I tried to leave us with a little bit of time. Do we have any other questions while I pull up the RTD? I'm going to pull it up for Vermont for everyone on my other screen while we're waiting. Any questions in there, Cody?
Not right now. Additionally, if anyone would like to come off of mute and ask those questions verbally, that's also perfectly fine. But if you don't want to, sending them in the chat's also good.
Yeah, if someone has a question, definitely love to have you if you're willing to voice it. If not, no worries.
Scott, I love the fact that you all meet once a week, and when you're done, you're done. You're not asking them, get to the point. Here's your mission. See you next week.
Yeah, thank you for reiterating that, because when people hear this originally, they're like, oh no, I can't do another meeting on my calendar. I will tell you that everywhere we go, people rearrange the schedule for this table meeting, and then they come back and say, you know what, that you were right. We've had a couple tables that have struggled. One of them has struggled because they decided to go every other week. Now think of this. You're trying to meet the needs of a family or a juvenile at risk. You can't wait 2 weeks to report back for that accountability. You got to do it that next week. And again, we get this process down with the tables, the chairs, that literally I have seen tables operate in 17 minutes, 22 minutes, almost never more than 30. I'll give you the example that happened in Rutland, Vermont. They took 6 situations in one meeting. I wasn't on the meeting, and I said to the chair, oh my Lord, that's a lot. Because now you have to put together 6 filter 4 teams. What I said I would have done is I would have jumped in at 3 and said, listen, let's triage this 3 this week. Let's table the other 3 for next week. And let's get out there and get those 3 tables going. But again, that accountability. No one wants to go back to a meeting in public. And I suggest you do it in person, at least to start, because that personal connection, I can't stress enough the impact, because you're going to benefit by sitting across from the table and saying, oh, hey, I heard your name and I saw your email, but I didn't know you personally. Now we have those relationships. But now that accountability, who's got situation 2025-002? Oh, that's me. I'm the school behavioral health partner. We had this situation. I partnered with the school resource officer. We engaged the 2 students. They're now in an IEP. Our behavioral health providers met with mom and dad at the house simultaneously on the same day. Mom is now into 30 days treatment. Dad has been removed from the house with a restraining order because this domestic violence. That's how that magic happens. But it happens because you're on top of it each week. And what we're finding is most of the tables that said once a week might be too much, they come back to us and say you were right. Some tables actually contemplate doing a second meeting each week just because they see the benefit. And again, they reorder their meetings. Or if you have an existing coalition meeting already, just piggyback that one meeting. And what we find is if you have a community meeting before, you host the community meeting, and then you go to a smaller or the smaller sit table. One question that maybe will come up or hasn't is we don't have the person or the family at the table meeting. you're presenting it on their behalf, or because they're at acutely elevated risk, you presented it to the group. So that gets asked a lot, like, do we have the people come in the meeting? No, they don't. And again, we respect privacy. Are you
Hey,
seeing
Scott,
my? Yep.
I noticed, yeah, there's a hand up. If you see that,
Okay.
Tahara.
Go ahead, Tahara.
Hi, good afternoon, everybody. So I actually used to facilitate the Roxbury Hub
Oh,
from its inception for
yes.
3 years. Yeah. So my question would be, because it didn't necessarily always have the police buy-in, right? So
Yep.
there was a disconnect. So that and harm was done to me, and primarily the harm was done when in Roxbury. I don't know where everybody's from, but when we had an influx of migrants coming in, um, we didn't know exactly what to do with that. The state didn't have a plan of action. The city didn't have a plan of action. So our community officers would, ask, well, what do we do? Because the hospitals also changed their rules. They no longer had to take the women and children under a certain age because there's no capacity. So of course, what I do, I reach out to our mayor's liaison, like, hey, we have some things going on within our community. We don't know how to respond to this. What is like the city's plan?
Yeah.
And that put things in an uproar where I
Yeah.
was told you don't have like city officials come in. I'm like, I don't understand why. If we have an influx of an issue, and as organizations, none of us had any, plan. We didn't know decisions were made without us, our governor. But we need resolution because these are human people. These are individuals, and harm is being caused by children sleeping in the cars with moms where there's a lot of substance use.
Yep.
And so I just wanted to ask your your feedback on something like that, and
Yep.
what would you guys would have done if it's really in the hands of the city and the state? Well, should be.
So we just did a refresher training for Roxbury, Dorchester, Jamaica Plain, and East Boston 2 months ago. Maria Chief through public safety, and Kelly Young and there's someone else in the mayor's office. I can't remember her name. We're re-energizing the tables. So the Roxbury table is now going through a new training process. And what we've done is the police are now brought in hook, line, and sinker. They actually have community liaisons that are at the tables. So what we do is, particularly when you mentioned the migrant population, we ask those agencies that are serving those populations, come to the table. Let's talk about it at the situation table. And what will happen is you might have a Roxbury situation that's for a neighborhood. Hey, because of these challenges, these are the things that are happening that are harm. What can we do as a community to then address those needs? So who did you work with at the mayor's office? Or who are you working with? Real quickly, I didn't want to, because I worked with them so closely.
Asha Janae is the
Yep.
Roxbury liaison.
Yes.
I know Maria
Yeah.
Shevins. I know
Yeah.
Caitlin, who's
Yeah.
now overseeing.
Yep.
Yeah, I know everybody. I was working at Madison Park Development Corp. But what I'm asking is, in other areas in which you are doing this work, if
Yep.
the agencies don't have resolve for something of that magnitude, would you guys reach out to your city and state officials like, hey,
Oh,
we have a huge issue that's going on? Like,
yeah.
it's
So
for the
what I do
community.
is, yeah, what we're doing in Vermont is I take this data and now we show it to the governor. So the Vermont Public Safety Enhancement Team, it's the Commission of Public Safety, Public Health, all across the board. And this is a governor-sponsored initiative. So we tell him your risk factors. This is Springfield, one town alone. I'm going to fly. Oh, let me see if I have it here. I hope I do. What I do is I take this data and I show the state leaders, the state representatives, the senators, the congressmen, the federal. Hey, your top risk factors are housing, mental health, negative peers, social environment. These are gaps that the table's bringing forward, but we're not able to resolve these situations because of X, Y, and Z funding. So they leverage this data to fill those gaps. Now, what I would envision in Roxbury is you're going to see a lot of risk factors that you might have. It might be basic needs, and those basic needs might be categorized by immigrant migrant population challenge. You can red flag this stuff and then use that data to leverage the funding and the leadership piece. So that's what we do across the country. We use this data all the time for just those purposes. Is that helpful for you?
That is very helpful. I appreciate
thing-
that because that's exactly what I was doing. But
Yeah,
I think I think the big issue was if you don't have buy-in from the police department, like the higher ups,
Yeah.
if they don't believe in this process, then they might see it as harmful.
Yeah. Well, your deputy superintendent, the female, she's awesome. Oh my God, I can't believe I can't think of her name for the commissioner's office. She's a champion. Her the superintendent, deputy superintendent, two leaders. I can tell you right now, Boston is all in. They're starting the downtown one this month, I believe. We just did two different trainings there. Any other questions in the chat or want to jump up? Great meeting you too. I love that we had a Massachusetts person. You can understand me, right? Now, I have a little post-training survey, but I know we got some breakout rooms. We got 4 minutes. Cody or team, do we want to do the post-training survey first, or do you want to do your breakout rooms? I'll follow your lead.
It's gonna take me a little bit to set up the breakout room, so go ahead and do the survey.
Can you guys click on that QR code and we'll pull that up? I told you I was going to make you work a little bit today.
I'm getting a no active poll.
Yeah.
Anybody
Hold
else
on, I knew
getting
that was
that?
going to happen. I had that ready, Romero, and I missed the mark. I failed here.
Oh, it's
I'm
all
going to have
good,
it open in a
Scott.
second.
It's all good.
That is 276079, right? I apologize. Oh man. Usually I have Prima here. Oh, get me here. All right. Should be open now. Try it again. Perfect.
To go too. I just seen Samantha's text. What did she say? Breakouts.
All right. I'm gonna pull this up. Perfect. We got 6 votes. Got eight people typing. Appreciate if anyone has any follow-up questions or I know we're talking about the youth integration. For those that don't know about the Handle with Care model, Andrea Dar and the Karen Yost in West Virginia, now JBS, they were the innovators in 2010. I can tell you that, and because of them in my community, I introduced Handle with Care. We're now doing it 8 years. I've been retired for 5 years. I implement as the chief, and we now have over 500 Handle with Care referrals. And the superintendent, who's my wife's best friend and what we all went to college together, she was the key to getting her once in the school district. They've never disciplined a Handle with Care. They've never had any negative interactions. Now they've had repeat Handle with Cares, but it's opened up this community sharing. So I just want to kind of highlight, knowing that we're focusing on this youth integration.
All right, breakout rooms are ready. I'm gonna stop the recording and then I'll resume it once we return from the breakout rooms.
Hey, everybody.
How are people's breakout rooms?
They
Scott,
were
yeah,
awesome. I didn't want to
really?
leave mine because we just got to chatting. So I want to start with kind of one of the themes in keeping with what we were just talking about, if I can ask Scott. One of the things that we were talking about was I think Jeannie brought it up and Catherine was talking about it, that after the pandemic, they have kids that maybe didn't get their developmental needs met. And now it's 5 years later. And we were just saying, I have had lots of discussions with legal partners that are like, oh gosh, we don't know how to talk to these attorneys. And sometimes they're not. This collaborative work that we are doing. And we were saying, are we really all okay now? Like, we're all relieved that it's over, but what's that looking like for your situation tables, and do you have any suggestions for those of us who are learning to like make friends and play nice and share information again after we were all stuck indoors?
Yeah, that's why I really stress getting in person. Like I just did even the pre-mobilization, we come out in person. Let's sit around a room, have coffee, have some, have some desserts, and then let's talk through them. So I can't stress that enough. The second part of it is, we definitely are seeing, that's why mental health disorders is like that number 2, number 3 across the country. So making sure you have the right players together. But to your point, I always start off, like as a police chief, I was involved in a lot of turf battles. So I always say, listen, let's break through those. So in that first day one, being in a room where we're talking to professionals that we don't normally work with, I think that's part of it as well. Having an understanding of, hey, I didn't know that you did this service, or I didn't know we had that service in our community. So I can't stress enough of just the willingness to sit in a room and talk through those challenges at the same time. That's the key. And that happens at the table every week. Forget about the situations. Someone's leaving there saying, hey, you know what? John's not at the table. Don't you have a relationship that can bring him? Yep. So it's relationships that bring partnerships that lead to true collaboration.
That's super helpful. I'm taking that away, that it might be the providers that are the situation, not the folks. So
Yeah, right. Oh, no, they are. We have a lot of, I call them territorial battles. Like, hey, I have an executive, model I have to follow. And so we're like, all right, well, how do we do this collectively? That's why no one owns the table. And then the table keeps everyone honest. Hey, listen, why are you the lead on all these? Maybe you shouldn't be the lead. I think Johnny provides a service or Janie provides a service.
that's great. I don't know if anybody else from my group, we didn't get to the question part because we were chatting, but if they had a question, if not, we'll pass it to the other facilitators.
We, in our group, someone brought up, the question was brought up, how do you address meeting fatigue? And I thought this answer was really good. You could have several representatives from your agency and you can alternate who attends as long as you get them up to speed and they have all the information they need. But if you had 4 or 5 people, assigned to that, that would space it out and that would address the meeting fatigue. And also food always helps. Have food and they will come.
Yeah, what we talked about is like every agency has a lead and a backup. Have like 4 people that share that lead role. As long as they can speak to when they hear risk factors, this is what our team does. That way they're only going to 1 meeting a week or 2. So we do have multiple agencies that have multiple team members that represent them each week.
Something else that came out of our group that I wanted to share and really seeing situation tables as a great solution when you have jurisdictions and areas that are, I think we hear this sometimes, resource rich but coordination poor, right? And where sometimes the need, we've got a lot of these great services, but people aren't accessing them in meaningful ways or in coordinated ways, which just creates a lot of chaos for families and children and young people, right? And so that being just sort of something that stuck with me in our breakout, like how that this could be a potential solution for those situations.
See, I can't even figure out how to unmute myself. And how many years have we been on Zoom? But we talked about that too. And for the families, our group talked about they've been involved in a lot of systems and they've maybe been helped a lot and it didn't really help all that much. And sometimes it hurts. So thinking about, if we're going to coordinate and use these situation tables, hopefully they deliver on what they say they're going to deliver.
Yeah, that's the one thing I always stress when we first started stuff is you can't make promises. So if you bring a situation forward and you don't have the right resource, that's where that collaboration. Okay, hey, we need X, Y, and Z. We need, out in Montana, we had challenges with people couldn't get enrolled in Medicaid. They made too much to not get enrolled, but they were in that in between. So we use that data to leverage to the state, and the TPHS said we have a pot of funding we're going to allow, referrals to use, so it problem solve together. So it's definitely not going to be a panacea. It's not going to fix everything, but it's going to allow everyone to have a voice at the table to then talk about how do we work through this challenge together.
Were there questions that anyone had that didn't get answered? Or thoughts that you wanted to share? Romero got kicked out of Zoom.
Oh, I'm sorry, I didn't notice that.
Yeah, I
How
got
did-
kicked out. Yeah, no, I lost internet we were in mid conversation and like, oh gosh, in my group. So
I thought Catherine raised a good issue. So, in larger communities, do you have hubs that are specific to that community, or do you have larger hubs where there is knowledge of kind of all that's occurring and the pros and cons of both? And, what do you think in regards to that?
Yeah, so in my county, we have 550,000 residents, too big for one situation table hub. So what we did is we trained all together. We set up 4 situation tables. They now just went through a retraining. They piggyback the same day of the week. So northwest, southwest, northeast, southeast. They meet the north meet Monday mornings 9 to 11, and then the next day is the southern ones. But all the tables talk to each other because the providers don't necessarily cross over those jurisdictional boundaries. So that's to your point, figuring out the right fit. In Boston, they have 4 hubs. They're going to start a 5th now. Each one, like the Roxbury one, serves that area. The Dorchester one, East Boston's across the river, across the bay. So they all have served their area. But the key is that each one of those tables must have like a monthly check-in, or they weekly check-in. Hey, we got a situation over here. It's going to come your way over in Dorchester, but it got presented by East Boston. So that's what we do in Plymouth County, and it works pretty effectively to cover, 500,000 people that live in that area.
Yeah, I was wondering because our families move all over,
Yeah.
right? So that was kind of what I was more wondering about.
Well, that's why at the recognition, when someone brings forward a family, and if you can do recognition, someone will hear that name or that family address and be like, oh, they're now over here. So again, that's why the filter 3 recognition is so important, because someone across the county or region will hear information that, oh yeah, no, I've worked with them before.
That's great to hear. I was saying, I think in our largest city in Nebraska, in Omaha, they would say, we've got too many kids, we've got too many situations, we can't do this, there's too much. So hearing about having the multiple hubs and coordinating with them makes a lot of sense to me.
Scott, I got a question. Like, when I think about how is power thought about being shared, within, there's a lot of egos, there's a lot of interests, there's a lot of stuff, within that space, So how is that balanced and how is that prepared?
So day 1, we start putting out, hey, who wants to be the table chair? Who wants to be data recorder? Organically, the natural leaders come forward. And then we say on day 2, we're going to do 5 mock situations. And we're going to spend the whole day doing them. Everyone's going to get to practice and play it. And then I can just tell you 40 tables across the country now up in Canada, organically, those leaders step forward. Now, the key that I see in the table chair is they're not a frontline service provider. They're the facilitator. They can recognize that, hey, we got 3 agencies that are all doing the same thing. How about, so it's got to be that independent person within a group. I mean, and it's different in different places. In some places, like I said, we have probation, parole, district managers that are the table chair. In others, it's the community-based organization that is already doing collaborative work. So, but then the table will have a conversation. Hey, you know what? Yeah, we're seeing some turf battles here. How do we work through it as a group, and respecting everyone's, their roles and responsibilities, but also saying, don't be afraid to step up. We'll take it right on. And I'll say, all right, who's not getting along here? We did it at one table, and they're like, well, we've been next to each other for 10 years. I've never met that director. Well, now you have. How do we break bread? So there's part of that, piece. But that is a big part of it, is how do we work together and check our egos at the door.
I appreciate that. I think that's important. Sometimes, folks stray away from conflict and even psychological safety and those types of things. So I think those
Yep.
types of moments help create that. And so I appreciate that. Thank you, Scott.
Any other questions or final thoughts? I think we got about 2 minutes left. Well, we appreciate this, Scott, so much. And if you guys want more information, we can always get you to Scott. So just ask whoever your coach is. And I know some of those are changing as we're getting folks assigned, but we'd be happy to have more information. And I think, yeah, I think you're all listening. Is the slide deck will be shared?
Yes. It'll be sent out. There will be, hopefully within the next month or so, the slide deck will be shared out to the email list, and which everyone here should be on that email list. So yeah, the slide deck and the recording of this, which will be uploaded to YouTube and shared with that email list as well.
Great.
Thank you, everyone. Appreciate your time and patience in dealing with my accent.
Thank you, Scott. That was great.
Yeah.
Great
Awesome.
presentation.
you.
Thank you.
Yeah.
Thanks,
Thank you,
everybody.
Scott. Yep.